Hello, everyone. Welcome to Hot Seat. I'm Omid Moghaddas from Tehran. Joining me today, a very dear friend, a very super talented surgeon from United States, David Wong, is here with me. Hello, David.
Hey,
So
Omid.
have you.
Thank you.
It's a
Thank you.
pleasure really for me, an honor that you accepted this invitation. And I'm very happy for all the dentists around the world that they can have the chance to enjoy people like you, their presentations, and their valuable knowledge that they share with the world. And it really means a lot. And thank you for giving me the chance to be your platform and for sharing your amazing skills with the world. Today, David's going to talk about soft tissue management around teeth and implants, which is one of the, I think, main demands for dentists and aesthetic surgeons around the world. So very interesting topic, and I'm sure a great discussion we will have at the end. And as a tradition, I will have first a CV of David for all of you, and then we go straightly to the presentation. Dr. Wong is a board-certified periodontist in private practice in Tulsa, Oklahoma. He received his undergraduate education and dental training at the University of Oklahoma, and then went to complete 3-year residency in periodontics at the University of Missouri, Kansas City. He's a diplomate of American Board of Periodontology, as well as fellow in the ICOI. He is published author in several peer-reviewed dental journals, but also reach a mainstream audience in media, such as Fox News and the Wall Street Journal. So we have a celebrity now also here with us at the hot seat. David, again, I'm so happy that you accepted this invitation, and we are ready for your amazing presentation.
Man, honor and pleasure is all mine. I mean, thank you so much for including me. You have a very esteemed stable of speakers coming your way, everybody. So I really appreciate the opportunity. I'm going to go ahead and share my screen, and we'll go ahead and get started, okay?
Sure.
All right. So all right, everybody. So what we're going to talk about today is soft tissue management around teeth versus implants, okay? And I called it flattening the curve just because of the COVID-19 themed title here. So the reason I said flattening the curve, because there's a lot of differences between how we manage the soft tissue around teeth versus implants, as far as graft materials that we select, as well as around the incision and flap design that we choose. So I kind of wanted to just spend the next hour and a half or so just discussing the differences and going over some cases that may look similar, and I'll explain that even though things may look similar, we do treat them differently, just kind of like these two photos that you see on this cover slide. So let's go ahead and get started. First of all, we're only going to be here for a short time, and I know we have a worldwide audience, you know, with Dr. Moghaddas being in Tehran, and I'm here in Tulsa, Oklahoma in the United States. We have a wide range of people. So if you ever want to get in touch with me, social media seems to be the best way to do it nowadays. These are my 2 accounts on Instagram, which, you know, is the best way for me. I have the first account is my main account. It's david.wong.dds. And then my more clinical account, where if you want to see more surgeries and things like that, it's just my account. It's called Plaque China. So go ahead and visit me there and shoot me a message if you have any questions after this, okay? So the goals for today, we're going to identify the differences between mucogingival deficiencies around teeth versus implants. We're going to talk about common graft materials, common flap designs, and then we'll also discuss the rationale for various graft materials and flap designs, depending on whether or not we're working around teeth or implants. So we've all seen a illustration similar to this, where we know that teeth and implants are not the same, right? So as an example, we know that, implants do not have a periodontal ligament, whereas teeth do. But when it comes to the soft tissue attachment, one thing that's less known for most people is that with teeth, the connective tissue fibers insert perpendicular to the tooth surface, whereas on an implant, the connective tissue fibers are more parallel along the side of the implant surface. So that's a little bit of a difference that we'll play on as we go throughout this presentation today. So teeth versus implants, do we treat them the same? So if you look at the lower incisor area, and we're going to talk a lot about the lower incisor area, because in a short period of time, that's the area where a lot of people have a lot of different opinions and approaches as to how to treat these teeth. So when we look at these cases on your screen, it's a very simple question. Do you treat these the same, teeth versus implants? What if we decide to show you an upper tooth? Do we treat these the same? Does your thinking change at all when we're talking about treating a recession on a tooth versus treating a recession on an implant? So let's start off just talking about teeth. When we're talking about teeth, just one little bit of terminology. Whenever we say mucogingival surgery or periodontal plastic surgery or oral plastic surgery, we're generally talking about the same thing or similar things there. But what these are they're plastic surgical procedures that are used to correct abnormal gingival mucous membrane relationships. When we talk about oral plastic surgery, we know that we can perform these as an adjunct to regular treatment for periodontal disease, or we can treat them independently, okay? But the main reason why we address these gingival mucous membrane relationships is because we're trying to widen or thicken the zone of the keratinized and attached gingiva. That's the whole reason that we do these things. So the rationale behind mucogingival surgery or periodontal plastic surgery is based on the idea that 2 millimeters of keratinized gingiva and 1 millimeter of attached gingiva is required for optimal gingival health. Now, when we read the literature, this varies. Some authors will say you need 5 millimeters of keratinized gingiva. Some will even say that you don't need any. Okay, so there is a little bit of debate there, but generally speaking, in the periodontal world, we want 2 millimeters of keratinized gingiva with 1 millimeter of that being attached. Now, the reason that we don't have enough attached gingiva, we have several factors. From a periodontal disease perspective, the base of the periodontal pocket can be at or apical to the mucogingival junction. We also have high freedom attachments and muscle attachments that may pull on the marginal gingiva and cause the tissue to separate from the surface of the tooth. Finally, we may have recession or receding of the tissue or the gums that expose the root surfaces. So what exactly are we trying to fix? The main reason that we need, the main correction here is to address the lack of keratinized or attached gingiva. We also want to eliminate or highly minimize the high freedom attachments. We also want to address the gingival recession and try to obtain some root coverage. And then, of course, in gingival deformities, we want to correct the tissue and make a nice positive architecture where it looks nice and symmetrical and harmonious. So when we look at issues like this tooth here, you can see exactly what we're talking about when we talk about a mucogingival deficiency. You see the exposed root. You can see that the marginal tissue is being separated from the root surface due to the high freedom attachment, and you can also see that there's very little to no keratinized or attached gingiva. So first things first, we have to talk a little bit about classification systems. Unfortunately, it's not the most exciting topic, but it just helps us to all speak the same language and know what we're talking about. So generally speaking, we use Miller's classification of recession, and there's 4 classifications. You want to treat patients obviously on more of the class 1. You really don't want to treat people when they're in the class 4. So the idea here is to treat, diagnose and treat early, okay? So class 1 and class 2, these are the more ideal situations for treating the gingival recession. And when we talk about this, the important thing about class 1 recession is that the recession does not extend to the mucogingival junction. So you already have some keratinized and attached gingiva present. There's no interdental bone loss, and that is the key, because when there's no interdental bone loss, that means you can have 100% root coverage. Now, class 2 recession is a little bit different because the recession does extend to or beyond the mucogingival junction at this point. However, the key point here is that there's no interdental bone loss. So therefore, 100% root coverage is still possible. Now, class 3 is different. That's when things change dramatically, because now the recession does extend to or beyond the mucogingival junction. But the key thing here is now you have interdental bone loss, and that's key, because once you have interdental bone loss, which patients often cannot feel when that happens, now you can only achieve 50 to 75% root coverage, and that could be an issue. Finally, there's class 4. So class 4 is the terrible one, because the recession extends to or beyond the mucogingival junction. However, the interdental bone loss is so severe that it actually extends beyond the limit of the recession. In this situation, no root coverage is expected at all. So the key thing when we're talking about treating gingival recession is, where's the bone? So when we look at a photo like this over the lower incisors, which we'll be talking about the most today, what are your treatment options, right? Because there's so many things you can do here. And if we poll everybody that's watching this, they're going to have different opinions as to what they do. Now, if we switch gears and look at the upper teeth, does your thinking change a little bit? Okay, do we treat upper teeth different than the lower? What about, do we look at the marginal tissue and how that affects our decision making? So let's dive into that a little bit more. For the purposes of today's discussion, we're going to talk about free gingival grafts versus connective tissue grafts versus acellular dermal grafts. So there's plenty of other graft materials out there as well, but we're going to stick to these 3 for the sake of being for being brief. So if we fail to plan, then we are planning to fail. Okay, this is a famous quote from Benjamin Franklin. So the questions that we need to ask ourselves are, what are the goals of treatment? What are the patient's goals? Is it to be comfortable? Is it to be functional? How long do we want the graft to last? What is our level of predictability with these different procedures? And then, of course, can we improve the health of the teeth, and can we get it to look better? My main question, or one of my main questions that I ask myself whenever I'm approached with a case, is, can I get root coverage? Okay, that is going to dictate immediately what type of procedure that I'm going to choose for my patient. Second question is, do I need more keratinized and attached gingiva? And thirdly, is the area technique sensitive? Meaning, how close are the roots together? How big are the papilla? How deep is the vestibule? Do we have any freniples in the area? Is the tissue thick or thin? This is all going to be very important for me whenever I choose a flap design, because, as an example, teeth that are too close together often have very small papilla, and that can be very difficult to work around. Vestibular depth can be a challenge too. If the vestibule is too shallow, it can pose an issue. Freniples pose an issue. Thin tissue also causes issues. So these are all things that we need to consider. Now, one of the other themes about this presentation is going to be talking about the difference between tissue management versus tissue rescue. Okay, there's quite a bit of difference here. When we're talking about teeth like this, generally we're still talking about tissue management. However, whenever we talk about recession on implants, unfortunately like this, we're more talking about rescue. And that's the big difference between teeth versus implants a lot of times. So when we look at the free gingival graft, and this is a free gingival graft that has been placed over the lower central incisors. And a lot of people do not like this type of graft because of the aesthetic outcome, right? It looks funny, like a tire patch, right? It's too white or too pink. So it scars. So there are some things about this type of graft that people do not like. But why do we do it, right? Why would we do something like this if it looks so terrible? Well, there's several reasons. So when we look at a lower incisor area where we have no keratinized or attached gingiva, we have a high frenum pull, shallow vestibule, very thin tissue, we look at predictability, right, and technique sensitivity. A free gingival graft, of the three graft materials that I just talked about briefly, it's by far the most simple, right? It's the most predictable. You can gain massive gains in keratinized and attached gingiva, and the frenum pulls are almost a non-issue at all. The only problem is that root coverage is not so predictable. And that is why I always ask myself at the beginning before I start, how much root coverage can I get? If the patient has a class 3 Miller defect, for example, where we have interproximal bone loss and root coverage is limited anyway, I may electively choose to do a free gingival graft a lot of times. The suturing is very simple. So if we're beginners or intermediates with our skill level or experience level, the suturing is very simple with a free gingival graft. And not only that, we don't have to secure with sutures the lateral or the apical borders. So this makes our life a lot easier. And what the outcome is once again, is very predictable. It establishes a very, very nice band of keratinized and attached gingiva. The elimination of the frenum pull is highly beneficial. And then you'll notice that the tissue is very stable, even in the presence of poor oral hygiene. So once again, when we look at these types of cases, a free gingival graft, when we look at the longevity, the predictability, the health of the tooth, it's ideal. The only thing that is not ideal is the aesthetics of it, if we don't like the way that it looks. But when we're talking about the lower incisor area, this is often the treatment of choice for many people. Not everybody, but for many people. When we do free gingival grafts, especially in cases even with periodontal disease where we have to do some, when we're using it as an adjunct to periodontal therapy, we can get a nice result for patients. So what about connective tissue grafts? Connective tissue grafts are a little bit different, right? So with a free gingival graft, what we're doing is we're going to the palate and we're taking both layers, meaning the epithelium and the underlying connective tissue. With a subepithelial connective tissue graft, it's a little bit different. That's what I'm going to show you next. We're going to separate the epithelium from the connective tissue and only take the connective tissue out from the palate and utilize it as the graft material. So when we have a situation like this, where we have recession with no interproximal bone loss in the lower incisor area, this is what a connective tissue graft looks like compared to the free gingival graft. And all we do in this situation is we reflect a flap and we suture the connective tissue graft material around the incisors, and then we advance the flap over the graft. Now, with connective tissue grafts, the beauty of them is that a portion of the graft material can be left exposed. You certainly want more of the graft material covered than you have exposed, but you can leave a little bit of it exposed, like you can see here on the central incisor. What that leaves you with over time as the graft heals is the exposed portion does become keratinized and becomes nice and thick, and you can see the result here. You have the main difference between a connective tissue graft and a free gingival graft is that you'll get more root coverage. It's a lot more predictable when it comes to the root coverage portion. But what you'll notice though in comparison to a free gingival graft is that you don't have as much keratinized and attached gingiva. It's still very good, but it's not as much. And you'll also notice that the freedom attachment is not quite eliminated. So to summarize, with a free gingival graft versus a connective tissue graft, you have less predictable root coverage, but you have larger increases in keratinized and attached gingiva. There's also more predictable elimination of the freedom attachments, much less technique sensitive. Okay. Now, going back to an advantage of a connective tissue graft, though, is that there are more variations and flexibility as far as the flap design. One of those flap designs that I can show you is a lateral sliding flap. This is something that's commonly used with a connective tissue graft. I wrote about this and did an update in this textbook, Advances in Periodontal Surgery, with Dr. Salvador Nares as the author here. But what we can do with connective tissue grafts is we can also utilize a different flap design called the lateral sliding flap, and that's what this is here. So here you can notice that we have 7 millimeters of recession on the mesiofacial root of an upper left first molar. So rather than coronally advance the tissue over all this very large recession defect, we look to the neighboring tooth next door, and all we're going to do is borrow that tissue. Okay, so you can see here is that once we have initiated our lateral sliding flap incision design, once the flap is released, because of the freedom pulls and things like that, the tissue is already going backwards towards the molar without any help from any dental instruments or any retraction or anything like that. Here, what we're doing is harvesting the connective tissue graft from the palate, and then simply putting in two sutures to put pressure over the palatal flap. And this is to help with control bleeding, and also makes the patient a little bit more comfortable. And then we'll secure the connective tissue graft over the mesiofacial root, and then put the sliding flap sutured around the molar as well. The middle photo, you'll notice this is the tooth, how the tooth presents at the 2-week post-operative treatment. And then on the far right is what the case looks like after 1 year. Now, that's the difference between a free gingival graft and a connective tissue graft. Okay. What about the acellular dermal grafts? This is where we're utilizing cadaver tissue. A lot of patients don't like utilizing their own tissue because of the secondary surgical site and the pain associated with that. So we use acellular dermal grafts whenever patients are fearful of the pain, or they have anxiety, if they're worried about recovery, maybe they have to get to work very soon. There are some things personal reasons why you would want to use an acellular dermal graft. But when we're talking about utilizing it for root coverage during our periodontal plastic surgery procedures, it's nice. It's much, much more beneficial when the marginal tissue is already adequately thick and keratinized, like you see here on this photo. Now, keep an eye, though, as we go through this case, look at the lower left canine. That's the one tooth in this photograph where the tissue is very thin. Okay, so see what happens when we use an ADG over that canine. So the other benefit of an ADG is that you can use it in a number of different incision and flap designs. So in this situation, what you'll notice is that a tunnel flap was not reflected. We utilized a tunnel for the lower incisors, and then basically a Zucchelli envelope flap design for the remaining teeth. So an envelope flap on the sides, and then a tunnel in the middle. Okay. The key thing with ADGs is that entire coverage of the graft material is essential. You should have no tension in the flap whatsoever. So once this has been secured, what I do is I move the patient's lip laterally and up and down to make sure that the flap is totally immobilized. This is what the case looks like at 2 weeks. And then once again, look at the canine, number 22, very thin still, even though we have some root coverage, it's very thin. Whereas if you look at the result on the other teeth, it looks very even thicker than it was before, and we've covered the roots. So this is what it looks like at a year. Excellent result on all the teeth, a fair result, I would say, on the lower left canine. And this is the reason why whenever we can, especially in this area of the mouth, we typically try to use autogenous tissue like a free gingival graft or a connective tissue graft. So the bottom line here is when we're looking at the lower mandibular or the lower incisor area, free gingival grafts are typically the frontline defense against the recession. As you can see here, when we put together a collage, this is how we typically manage lower incisors because of many reasons, but mostly because the tissue is often so thin. We have a high midline freedom pull and the need to obtain, thicker keratinized and attached gingiva. This is why we use free gingival grafts so often in this area. Now, maxillary teeth are a little bit different, right? So we look at some of these cases like this where we often have more generalized recession on the upper. Maybe it's from toothbrush abrasion or occlusal issues or both. Generally speaking, we have more generalized recession defects a lot of times in the upper teeth. The benefit, though, is that a lot of times with upper and anterior teeth especially, you actually have adequate keratinized and attached gingiva. We just don't have a very nice smile, right? We see a lot of the roots exposed. The gingival architecture just is not very pleasing to the eye. Of course, we also have other things like root sensitivity that are associated with root exposure. So in a situation like this, for the upper teeth, a big papilla, very deep vestibule, lots of keratinized tissue. If we just want to manipulate the gum tissue and grow it down, just choose your favorite incision and flap design. Really, there's no specific guidelines, especially when there's no interproximal bone loss present. You can utilize whatever you want. You can use vertical incisions. You can use an envelope flap. You can tunnel. You can not tunnel. You can tunnel every other papilla if you want to. There are just so many different ways you can handle these. They all work in a situation like this. So the results in cases like this are always dependent on the interproximal height of bone, the IHB. So if we walk you through this case, all we're doing is I chose an envelope flap design again for the most part. The only area that I chose to tunnel was the papilla between the central incisors. And you can see this is our final result here. It's about, not 100% root coverage, but it's about 99. Okay, it's quite a good improvement for this patient. Once again, the benefit of the ADG also is that we can graft a large area utilizing cadaver skin. So this saves the patient's palate and therefore allows for a lot less morbidity and pain here. Now, what about grafting around implants? That's so much different. So much different. Soft tissue management around implants is vastly different than grafting around teeth. And I put this quote in: I not only use all the brains that I have, but all I can borrow. I am the master borrower. So I don't have a whole lot of original ideas, unfortunately, but I tend to read a lot and see a lot and try a lot. So I've borrowed several different ideas from people that have influenced me throughout my career, and this is what I bring to you today. So there's 4 factors affecting implant aesthetics. This comes from my good friend Lyndon Cooper's paper. 4 factors. Number 1, existing gingival levels. These are things that we do not have control over with our patients. They just come to us like in a case like this where they have trauma, right? An accident where they lose teeth and that has affected their existing gingival levels. Sometimes patients don't respond the way that we want to our surgical and our restorative treatment. Factor number 3 is the implant depth and position, right? Where we place our implants also impacts where the tissue will wind up. And then finally, how we manage the tissue with things like abutments and crowns affect the way the tissue looks. So The biggest difference between working around teeth versus implants, of course, is the surface, right? Working around cementum and dentin is a lot different than working on titanium. Also, when we talked about earlier about the importance of the interproximal bone height, that is so critical. So one thing we'll notice is that the IHB, or the interproximal height of bone for implants, is a lot of times much lower or more apical than the bone around teeth. That's just the way it is because of a number of things, not including but not exclusive to crestal bone loss, deep implant depth, thinner tissue, and that type of thing. So a lot of times the bone around implants is not as good as the bone around teeth, unfortunately. Papilla size is different. We have bigger papilla around teeth than we do implants. Matter of fact, every time somebody says, try to figure out which is the anterior implant, that's the trick, is always look at the papilla on the adjacent teeth. It's always almost always the tooth with the smallest papilla is the implant. So location of the CEJ, okay? So where we have the crown and abutment junction is a lot of times different than where the CEJ is around teeth, and that can also affect how we treat implants. So what is soft tissue management? So when we talk about the definition of management, what it is quite simply controlled direction. Control being the key, controlled direction. What is the definition of, backing up here, so what is this? Is this controlled direction? When we see a case like this, are we really in control at all, right? I say no. I think in a situation like that, we're in a rescue situation. What's the definition of rescue? Rescue is to free from danger or distress, or to recover. So cases like that are more of a rescue mission to me. So when you look at a case like this on your left-hand side compared to the right-hand side, you'll notice that for me, one is more management, the other one is more rescue. And that's the key difference between teeth and implants a lot of times. When we talk about 4 rules of tissue management around implants, I try to keep things simple, so I have 4 rules. Number 1 is have a plan. If you fail the plan, then you plan to fail. So we need to have a plan. Just don't treat, the pain, the pus, and the bleeding, right? We actually have to have a plan as to what's next. What is have a vision for what the final outcome you want. Number 2, know your biology and let it work for you. So these are 2 cases that I've treated, and the thing that I want to make sure I'm clear about is, when you look at these cases, even before you take out the teeth or before you do any treatment, know the biology. As an example, when you look at the case on your left, the tooth is short, it's very square. That's good. From an implant aesthetics perspective, that's going to be much easier than the case on the right, where the tooth form is very long and very tapered, right? And also the tissue is thicker on the left case than the right case. The right case has a black triangle already. The left really does not. So the case on your left is going to be much easier to treat from an aesthetic perspective than the case on the right. These are all things that we can see before we even touch the patient. So in addition to that, knowing your biology is thinking about other disciplines of dentistry that can help us, such as ortho extrusion. There are other grafting things, so that when we talk about grafting, we don't always necessarily have to talk about materials and flap design. Sometimes we look at other concepts, such as partial extraction therapy, where we leave part of the root. Sometimes we look at immediate implant placement, things like this that help us. And then also we can add grafting at the timing of implant placement. So, the timing of grafting is also something that we can consider. When we're tasked with trying to rebuild a ridge, the question always is do we do the soft tissue first, or do we do it after the bone grafting, or do we do it after the implant is placed? The generally, my advice is to do soft tissue grafting as early as possible. And finally is being patient with restorative treatment. So we need to be patient with the tissue and take the time to train it with proper healing of abutments, custom healing abutments, provisional restorations and things like that. Take our time, because there's a lot of difference between the case, once again, on the left versus the case on the right. The case on the right is going to be much more aesthetic, much more comfortable procedure to the patient, whereas the one on the left, where only a healing cap was placed, this patient is going to experience a much more uncomfortable crown delivery procedure. It's not going to look as good. The tissue is going to blanch and things like that. So be patient and do the right thing to properly train the tissue. So let's go over a case when we talk about management. So this is one of those cases that I just showed you. So when we look at tooth number 9, the left upper central incisor, you'll notice that we have a horizontal root fracture that's making the tooth non-restorable. You'll also notice that this lesion has been there a long time, and that's why we have a vertical periodontal defect on the mesial aspect of the tooth. So the things about this case that we see: horizontal root fracture, periodontal defect. There's a small periapical radiolucency, and because of the periodontal defect, you'll notice that we have a poor interproximal height of bone, both on the mesial and distal of this tooth. So there are some challenges here. In addition to that, the tooth morphology is not favorable. It's very long and tapered. We have very prominent papilla, even though the patient's lip does not go all the way up to the zenith of the gingival margin. You can still see quite a bit of tooth and papilla. There's already a black triangle, so this is something that we need to consider when we talk about taking out the tooth. And then we also have a very high smile line, okay? Now, the reason I say a high smile line, even though you don't see the top of the gingiva, is that in the smile, the papilla show 87 to 100% of the time when we look at Dr. Stephen Chu's paper here. We also know that the average papilla height of the maxillary the maxillary anterior teeth is approximately 40% of the tooth length. Okay, so we know the size that the papilla should be. So the thing about these cases is that we know as soon as we take out the tooth, in a case like this, the tissue is going to want to collapse. And whenever we can, in order to avoid this collapse, a lot of times we try to do an immediate implant placement and immediate provisionalization. That often is the correct answer for preserving the present gingival architecture. The problem in a case like this, sometimes it's a little bit of a gray area because we have so much bone loss. We have to address the periodontal issues as well. So if we're not confident in that, we do have ways to still manage the tissue. And I'll show you just one example here. So in a situation like this, what we've done is just fill the socket with bone in a basic socket graft. Now, the biggest mistake that you can make in a case like this is just stopping right here and just only doing the socket graft and not doing anything else. So what we've done here is a little bit of a modification. So rather than just do a basic socket graft and allowing the tissue to collapse, which would be disastrous for this case, we've done a graft that we call the modified socket seal surgery, this is from an older paper from Dr. Carl Misch, where we take an autogenous piece of bone and soft tissue from the tuberosity using a trephine drill. So you'll notice that there's bone and soft tissue present in this one graft. And then all we do is, because it's the perfect shape from the trephine, is we'll put this in the coronal part of the socket, and then we'll just suture it together. So what this does is it grafts the socket with bone to address the periodontal defect as well as the socket defect, but it also will help support the papilla and replace some of the soft tissue. After about 4 months, then we come back in and we do our surgical planning, because our next goal here is to not reflect any tissue if we can help it. So we try to go flapless with our next phase. So here we're utilizing the 3-2 rule of implant placement. You can see on the left, the periapical film shows that the defect is fully filled. And then here's our surgical planning. But what the 3-2 rule is we try to place the implant 3 millimeters apical to the free gingival margins of the adjacent teeth. And then we try to place the implant 2 millimeters lingual to the facial plate. So that's what you can see here on our plan. So at this point, we've utilized a static surgical guide. We've placed the implant flaplessly so we avoid any excess trauma to the tissue. And here you can see the periodontal defect is filled. And after a few months, then we go ahead and place the provisional restoration to start training the tissue. Now, what you're going to notice in a case like this is that her facial tissue is still quite thin, even with the grafting. But the big thing I want to point out is that she's developed a black triangle that she did not have before, even with hard and soft tissue grafting. Now, we're still in a very good position though, because the periodontal defect that we treated is full. So we've improved the interproximal height of bone. So remember this, the papilla show 87 to 100% of the time. So we need to stop looking at how high the lip goes and more at the papilla. People notice when there's no papilla. At this point, a lot of times when we look at provisionals and in dentistry, we tend to get in a hurry, right? We want to fix things so quick. So we always want to do surgery all the time. So when we see this, it's important to not get too excited, okay? Just be patient. Once again, patience is very key, because what we notice, especially when we look at literature like Yuli Grunder's paper, where they observe papilla volume actually increases an average of almost 0.5 millimeter after 1 year. So when we look at the final restoration after 2 years on this case, you'll notice that the papilla, because of the interproximal height of bone, it returns back to the preoperative levels. So it looks virtually the same as far as the black triangle and the papilla height. So cases like this are things that we can think and manage from start to finish. That's what we call management. These cases here that I'm showing you, these are all patients that have already come to us. We have no say in what happened up to that point. We can only control what we can do afterwards. So these are all rescue type cases that we'll talk about here in a second. So going to our second case here, is soft tissue grafting indicated in a situation like this? We see a large defect in the lower incisor area. From the occlusal view, you can see how dramatic that defect is. So we know that the patient is going to need some type of a ridge augmentation to accommodate implants. But how do we do that? And when do we do that? So before we get started, how important is keratinized tissue? We have some common assumptions about keratinized gingiva, which is that you have less inflammation, less bleeding, less plaque, less recession, and less crestal bone loss. When we look at the literature, some of it is confirmed, right? So this is a paper that was in the Journal of Oral Implantology. And what they noticed around implants is that when you have less than 2 millimeters of keratinized gingiva, you do get an increased recession, increased clinical attachment level loss, more plaque, more inflammation, and bleeding. When we look at systematic reviews, though, it's a little bit different because it's hard to find all the same inclusion criteria. But what they noticed here is that with less than 2 millimeters of keratinized gingiva, you do get higher plaque and more inflammation around the tissue. There's more bleeding. But when we look at probing depth and implant survival, they say that there's not enough information on the value of keratinized gingiva. But the only reason they say that is because there's not enough studies that have the same criteria. When we look at other papers, some even say the opposite. This was in the J. Perio. In the presence of really, really good oral hygiene, which was the key factor in this paper, they could not confirm increased recession with the lack of keratinized gingiva. However, they did note that aesthetically, patients preferred keratinized gingiva around implants. They liked the appearance of it, and I'm going to show you some more in social proof information about that here in a second. When we look at all of our papers, this isn't all of them, but it was just about 12 or so that I looked at. What's interesting about these papers is trying to answer the question, is keratinized gingiva important for implant health? 6 of them said yes, and then 6 of them were like, I don't know, not enough information. So for the most part, the implant dentistry community values keratinized gingiva as important for optimum implant health. So what about gingival biotype? When we talk about gingival biotypes around implants, we're often talking about thin versus thick biotypes. So generally speaking, with thick biotypes, it's very much the same as having adequate keratinized tissue. We see less recession, less inflammation, and improved vascularity and graft stability during bone augmentation procedures. And just a few papers to support this. And the last point there about improved vascularity and graft stability during bone augmentation procedures is very key, especially if we're beginners or intermediate in our skill level with bone grafting or ridge augmentation procedures. Thick tissue also is associated with improved aesthetics. Lastly, let's talk about vertical gingival thickness. So when we talk about implants and vertical gingival thickness, you can't even bring this topic up without bringing up our Lithuanian colleagues, Thomas Linkovicius and his group. They often talk about the zero bone loss concepts, and one of the important parts of this concept is thick vertical gingival height. So the height above the implant, the thicker the better, because thicker vertical tissue is associated with less crystal bone loss. So in addition to wanting keratinized gingiva, a thicker biotype, and thick vertical gingival thickness, that brings us to this chart here. We have so many different grafting possibilities. Even with just looking at autografts and allografts, when we look at the various donor sites and flaps and incision designs, there's lots of different things that we can do. So I don't want to confuse us too much. This is why I say let's flatten the curve. Let's eliminate all the noise and really get down to how we make decisions. So if we want more information about this talk, this is in my chapter in implant aesthetics. Editor here is Dr. Dwayne Caratu, good friend of ours as well. So when we talk about soft tissue management around implants, the key thing here is where we always begin is thinking about the long-term health of the implant. We obviously, for the patient, we want them to be comfortable and we want them to be able to function and eat with their implants. And then finally, we'll consider the aesthetics. But the first thing is we want healthy implants. So going back to this case, what do you do first? We understand that we're going to eventually need good keratinized tissue. We eventually need more bone, and we need implants. So what order do we do all of that in? Generally speaking, we do the soft tissue first in a case like this. Now, not everybody will agree with me, okay, and that's fine. But what I do, I love Jay Siebert's work that he's done with Dr. Salama. Beautiful approach, very predictable approach, I might add. So once again, we like thick tissue because of the less recession, less inflammation, and improved vascularity and graft stability for our bone augmentation procedures. So we'll start with the soft tissue first and establish a nice foundation so we have nice tissue to manipulate for the bone. So here we've done a very thick free gingival graft from the right side of the patient's palate. And you can see how thick it is as we suture it into place. Once again, I love this type of a graft because it's not very technique sensitive at all. This is with the graft sutured into place. There's only 3 interrupted sutures along the cristal ridge there, and then 1 periosteal anchoring suture, as you can see, around the incisor. And that's really all the sutures that we utilize to secure the graft. 2 weeks post-operative, you can see that the graft is already revascularized, looking very nice. And then I'll flash forward to I'll skip all the other stuff to show you the final result here because we don't have a whole lot of time. But here are the 2 implants placed with the implant bridge. And you can notice exactly what we tried to accomplish has been done. I have lots of keratinized and attached gingiva, no frenum pulls. The tissue looks very, very nice and healthy. This is from 2007. I'm sorry, that's hard to see. 2007 to 2015. So this is an 8-year result. Very stable, healthy, soft tissue. Now, how do we manage a failed implant site? This is very similar, a similar approach. So this gentleman comes in, and once again, this is really not so much management at this point, but we can manage it from this point forward. So this gentleman comes in, his radiograph didn't look too scary to me, right? The first thing I saw was the radiograph through an email. But when he came in and he pulled his lip up, I could see that there was a large fenestration in the middle of the soft tissue. So clearly the implant, needed to be removed at this point because there's no bone on the facial aspect, and when we have uncontrolled inflammation, the implant has to go. So just like what I said earlier, when we take the implant out, what we like to do, and this is what it looked like on CBCT, when we take the implant out, what I like to do is do a free gingival graft at the same time. Okay, that's what we see here. Now you'll notice that the interproximal height of bone is not good. He lost so much bone already, so we'll have to rebuild that in the future. But what we're doing first is a free gingival graft like this to establish a nice thick tissue to begin with. So this is what the graft looks like 2 weeks post-operatively after the implant has been removed. Now 3 months later is when you do the bone grafting procedure to augment the ridge. I chose guided bone regeneration. So here you can see how narrow the ridge is after the implant has been removed. So now we're trying to rebuild the bone. So we've performed our cortical penetrations into the plate. And then we've placed a tenting screw in the facial aspect. And then what we're doing is we got a little bit of some PRF membranes utilizing the patient's own blood. And here's a bone scraper that we used to obtain some autogenous bone to mix in with a little bit of mineralized cortical bone allograft combined with a little bit of xenograft as well. So we have a nice composite graft here mixed in with our PRF to make sticky bone, okay? So here the sticky bone is placed over the facial plate. We build it out nice and wide. And then we placed a couple of membranes and secured it with some anchoring sutures. And then we just simply close, okay? 6 months later, we come back with our surgical guide fabrication. Here's our implant planned here. We have adequate bone at this point. So we're going to come back in and place our implant. And we decided on a 2-stage approach in this situation. And then here, after the implant site is healed, you can see the nice keratinized tissue from the previous graft. The patient obviously has other periodontal problems as well, so he's going to address all of these issues all at one time. But for now, what we have him in is just a provisional restoration. You can see, fortunately, he does have a pretty low smile line, but for now, he's only in a provisional restoration until all the other periodontal issues can be controlled. So, moving on to our next topic, which are mucogingival issues around implants. So, once again, this is not management. This is more on the rescue side of the spectrum. But when we're encountered with these types of cases where we have recession on the lower incisor implants, this can pose a problem when we have this much implant exposure. On top of the implant exposure, we also don't have any keratinized or attached gingiva. There's a high frenum pull. The implants may be too big, maybe they're too close together. There's all sorts of issues here that are out of our control. But now the question is how do you treat this? So for me, the choices really just boil down to either a free gingival graft or a connective tissue graft. soft tissue allografts, the acellular dermal grafts, those things don't tend to perform very well in cases like this. So I always restrict my choices to two: free gingival graft or connective tissue graft. So how do you decide between the two? Remember, we're trying to establish health first. We can worry about aesthetics and everything else later, but for now, we got to get the area healthy. So here I've chosen a free gingival graft. And the reason I chose a free gingival graft is because you can place it submarginally where we don't involve any incisions around the marginal tissue. Why are we afraid of incisions around the marginal tissue? Okay. The reason that is because if we reflect the facial flap and things don't go well, the patient can be left in a worse aesthetic position than when we started. And then, of course, they blame you because you're the last person to touch it. So that's the biggest advice I have is around diseased or compromised implants. The less you can touch the marginal tissue, the better off you are, especially if the patient is not planning on redoing any restorations. Okay, that's really critical. So here, what we're trying to do is save the prosthetics that the patient already has. So in this situation, we're just going to stick with a free gingival graft. This is 2 weeks after the free gingival graft. Remember, the huge benefits of an FGG is that we have lots of keratinized tissue afterwards. The frenum pool is gone, and this resists lots of trauma. Okay, so you can see here, after a year, we also have creeping attachment that's covered the exposed implant collars as well as the abutments. So this phenomenon that we call creeping attachment is often observed around free gingival grafts, around natural teeth. Matter of fact, we look at the classic paper from Mate, for recession 3 millimeters or less, mean coverage is about 70%, which is pretty amazing when considering that we don't even place the graft on top of the root. But keep note, creeping attachment is typically observed on natural teeth. We don't know that this happens on implants or how often this happens on implants because we don't have a whole lot of studies. We only have this 2 case report paper that I could find where there's creeping attachment noted on recession around implants. But I can tell you anecdotally that this does happen quite a bit. Here's just another example of recession around implant on number 23, the lateral incisor. Just real quickly, here's the case with the free gingival graft on the facial aspect, and you'll notice that over time, 1 year, 2 years, then I lost track of the patient, so she had to send me a bathroom selfie picture. Even at 3 years, there's lots of keratinized tissue that lasts around the implant, and we have creeping attachment up on the implant surface as well. And you can see this example again on the left side of your screen at the top case. You know, there's creeping attachment associated with the free gingival graft again. So this does happen quite a bit. The video that you see on the right, you'll notice that it's just there because I'm showing you how relatively simple it is to place a free gingival graft onto the soft tissue bed. Really all that's necessary is just a few sutures, okay? So going on to more recession around implants. Let's look at this case here. We have a recession around implant number 9. When the patient smiles, she can see it. She does not like that. Only thing is she wants a relatively simple solution. She does not want to go and remake the crown. Okay, she wants to keep what she has for now. She just wants to improve the soft tissue. So in a situation like this, what do you do? Okay, what are the common treatment options here? It's funny, earlier I mentioned that I'm on Instagram, and what's interesting about Instagram is that you get to get feedback from dentists from all over the world. So when we talk about treating this case, I often will ask my followers, what they would do. So in a case like this, where you have very thin facial tissue, there's a high frenum attachment right between the 2 teeth. Plaque control is not very good because of the implant exposure. We also may have facial positioning of the implant, and then of course the patient's limited finances. what is the simplest solution for this patient? So in my Instagram poll, I asked simply, this is an ailing implant, do you fix it or remove it? It's about 50-50, right? A little bit more people wanted to remove the implant compared to fix the implant. And then I said, if you choose to fix it, do you do a connective tissue graft or a free gingival graft? And most people said a connective tissue graft. And I didn't ask why, but I suspect that most people do a connective tissue graft for aesthetic reasons. In this situation, however, I felt because of the ailing implant and the delicacy of the marginal tissue, I did not want to interfere too much with the marginal tissue, especially the papilla between the two incisors. So I chose a free gingival graft. And this is what the bed preparation looks like. Here's our simple free gingival graft. This is what it looks like at 2 weeks, 3 months, and 1 year. Okay. Now you'll notice that the crown certainly should probably be redone. But if you look at the final result at a year, when we talk about health being our first goal, that's a nice healthy implant at this point from a soft tissue perspective. Lots of keratinized tissue, thick gingival biotype now, no high frenum attachment. So from a health perspective, everything looks good. Aesthetically, it looks a lot better. It's not perfect, but it's a lot better. Not a bad solution for her. Now, whenever the time comes, whenever she gets the money to replace the crown, she can then do that. Now, when would you do a soft tissue, a subepithelial connective tissue graft? So this is a situation here where the surgeon tried to do try to manage aesthetically with a two space. So the patient was missing number 6 and number 7, the canine and the lateral. And what they've done is they've placed an implant for number 6 and cantilevered over to number 7 to try to preserve as much of the papilla as possible. But as you can see here, there was a collapse of the papilla on the facial aspect only, and there's still a little bit of a black triangle. So if we're trying to create volume in this papilla area, we have to go with a connective tissue graft, okay? You can't go with an acellular dermal graft because it will shrink too much. So the best way to create volume in a situation like this is a connective tissue graft, but specifically a connective tissue graft that's taken from the tuberosity. And that's the reason that is because tuberosity grafts minimize shrinkage, and the tuberosity graft consists of more dense fibrous connective tissue, and that's why it shrinks less. So what we've done here, remember around implants, the key is to try to not to touch the marginal tissue, because if things don't work out, and sometimes I like to think of the worst case scenario, if things don't work out, you can often get more recession and things can get worse. So we don't want to do that. So we've done a connective tissue graft from the tuberosity to minimize shrinkage and to gain volume. And then secondly, we're using a vestibular approach, so we're not disturbing the marginal tissue. So we're utilizing sutures to bring that connective tissue graft into place. We just suture it, the mucogingival line. It's just a straight line incision at the mucogingival line, by the way. And then we simply suture it with some, this is nylon suture. This is what it looks like at 2 weeks. That's the patient smiling here. This is our before, and then here's our after. Okay, this is at 12 years. So it's a very stable type of a graft. It's a way to salvage the implant and obtain a more aesthetic result for the patient without a large aggressive surgery. Now, when would you do a sulcular approach? So sulcular approaches are nice too, especially if you tunnel. So in a case like this, the patient is just complaining about peri-implant mucositis that's unresolved even after multiple debridements. It just stays red. So we decided to add a connective tissue graft to transform that facial tissue and make it more even thicker than it already is. So here's what we're doing is a sulcular incision around the implant. We're going to do a tunnel flap. So once again, in a situation like this where the tissue's on the delicate side, You don't want to reflect a big flap unless the patient is committed to replacing the restoration, or possibly restoring other teeth or whatever. They have to commit to more restorative work if you're going to reflect a flap. Flaps around diseased implants can be dangerous. So here is our small tunnel flap. We're placing our connective tissue graft into the tunnel. And then here's our before and here's our after. This is 13 years post-operatively. You can see the connective tissue graft has changed that marginal tissue very nicely to a biotype that's thicker, more keratinized, and attached. What about this case? So this lady comes in, and once again, this case can be managed many different ways, okay? In her situation, she wanted a surgical solution. She did not want to consider any restorative therapy because she has already been to 3 different dentists, and they've already replaced the crown 3 times and used 3 different abutments. So her confidence level in dentistry is not very high. She just wants it done with surgery if possible. I told her ideally she would go to a dentist that knows what they're doing with the soft tissue and management with the abutment in the crown, and simply just get a new abutment in a crown. She said no. Okay, so what do we do in a situation like this? So radiographically, you'll notice that the implant looks pretty healthy, but you can also see obviously she's unhappy with the exposed abutment. So in a situation like this, we identify the gingival recession, but unlike the cases previously, we do actually have adequate keratinized and detached gingiva. We also don't have a freedom pull in the area that's of any significance. And then you'll notice at the distal facial line angle, there's a small facial concavity in the soft tissue. So we have a little bit of a gingival deformity as well. So with restorative not being an option because the patient does not want it, what are our surgical options? So going back to our Instagram poll, and what's interesting about this is that we have the exact same amount of recession on this implant as we did on the previous implant that I showed you on the implant number 9. But whenever we go to an Instagram poll, instead of 50-50 people wanting to take it out versus fix it, now 89% of the people want to fix it, right? And they still favor a connective tissue graft over a free gingival graft by 72% versus 28%. I suspect that the reason that is because the keratinized and attached gingiva makes the tissue and the implant look much healthier, okay? And that's why people are more apt to try to save this. So here, what we're doing is just harvesting a connective tissue graft from the left side of the palate. And I favor a single incision line approach for me. And then here we're just using a 15 blade to go in through the single incision line. And we're just going to free up the connective tissue graft underneath through a combination of blunt and sharp dissection. This is just an example of the blunt dissection right here. So here what we're doing is just separating the connective tissue graft from the underlying bone, and then we're just going to sharply dissect the connective tissue graft out of the palate, as you can see here, and then we have a nice large piece of connective tissue. I always like to obtain more than I need. That way I can trim it back if I want. And we have a nice, neat wound. So here we treat the implant or abutment surface very much similar to how we would treat a tooth. We just obtain a burr and we actually just try to establish a nice flat surface for the graft to attach to. So we're just removing a portion of the abutment, trying not to thin it out too much. But after we do that, we use a tunnel flap design like we did before, and we insert the connective tissue graft into the tunnel, and then we secure it with just some resorbable sutures here. This is what the case looks like at 3 weeks and 1 year. So here we're pretty pleased with the results so far. Nice keratinized and attached gingiva. So far the tissue looks nice and stable. there's no reason at this point why it looks like the tissue should recede any more than it has right now. So that is just another approach utilizing a connective tissue graft and a tonal flap. Now, going on our last subject here is the VIP CT graft. This stands for the vascularized interpositional connective tissue graft. Now, why would we do this? And I'll show you a brief overview very quickly. So here, the patient is going to have tooth number 7, the upper right lateral incisor replaced, and you can see a facial concavity there. The tissue is very thin, and matter of fact, you can see that the tissue almost looks reddish, and even purple in some portions of that area. So, at the time of implant placement, what we decided to do was augment the soft tissue at the same time using this VIP graft. So here we're separating through a single line incision the connective tissue from the underlying periosteum. And then rather than separate the connective tissue from the palate like we did just now in the previous case, we're actually going to leave the blood supply intact. So we don't separate the graft from its blood supply. It's still intact. And now all we're doing is flipping the graft over to the recipient site like you see here. And then what we've done here is we've left a portion of the lingual flap, and we're just tucking the connective tissue underneath that graft, underneath the lingual flap, so it's nice and secure. And then as it's closed, you'll notice that it's very nice and clean. This design is something that I learned from Dr. Mike Picos, where he leaves the lingual flap intact and just tucks the big advantage of a VIP CT graft is the ability to maximize tissue volume and without excessive shrinkage of the graft. So let's talk about a couple cases here. So the first one we need to talk about is this is a young dental assistant who had the misfortune of having her employer, a dentist, place an implant for the upper left central incisor. And you'll notice on the right side of your screen, she eventually ended up with 2 implants, and I'll share with you why real quickly. So originally she had a failing root canal treatment of number 9, the upper left central incisor. Her dentist recommended taking out the tooth and placing an implant immediately, and he chose to do the case himself. But the problem is whenever he removed the tooth and placed the implant immediately, in order to get primary stability, he actually placed a very large implant and a very long implant. And unfortunately, during the process of this, he accidentally hit the adjacent tooth number 10, which later required a root canal to get this young lady out of pain. The problem is eventually the tooth that did not fix the problem, so she ended up losing both the implant as well as the tooth. Here you can see the implant's position is way to the facial that we often see with immediate implants with people who are just now starting. The implant learning how to do implants. So she eventually lost both the implant and the lateral incisor. Through a series of other misfortunes, she eventually found an oral surgeon friend of mine who was able to augment the site laterally or horizontally, but was not able to recover any of the lost vertical bone height. So here we have 2 implants, and this is her provisional. So whenever I asked her what she wanted us to help her with, she said, "Dr. Wong, I only want 2 things." And I said, "What's the first thing?" And she said, I want the gingival margins of the 2 front teeth to match." I said, "Well, that's pretty easy. They're only about 2 millimeters off, so that's okay. That's easy." I said, "What's the second thing?" She said, "Well, Dr. Wong, I want to have the papilla between my teeth back." And my immediate reaction was, there's no way. It's not possible. And the reason I say it's not possible is because the implants are buried so deeply that there's really no interproximal height of bone to work with, for one, which is what I've been telling you is important all along. But number two, our existing gingival levels are so poor. There's no papilla. There's even negative papilla between the two implants. So this is what we look at on our radiograph. The two provisionals, this is how deep the implants are placed. It's not in a very favorable position for us at all. Also, whenever you look at a chart that shows us, how tall papilla typically are between various dental restorations, whether it's implants or natural teeth, you'll notice that the papilla between two implants is, on average, is observed to only be 3.5 millimeters tall. Whereas if we go implant to a pontic, you gain an extra 2 millimeters to 5.5 millimeters. The problem is that her crown height space was so tall that her surgeon that placed the implants, it wasn't me, her surgeon that placed the implants chose to do 2 implants for stability. The problem is aesthetically, we're in a very, very compromised situation. So remember, 4 factors affecting implant aesthetics are the existing gingival levels, which are poor, the implant depth position, which is also poor, response of the tissues to implant procedures. So far, her experience has been poor. So we have no way of really managing any of the tissue at this point. So what we've decided to do for her is, rather than to put her through more surgery and even less and less predictability, we chose to do a VIP CT graft. So here's her pre-op photos. Now what we've done here is we're harvesting the connective tissue graft from the left side of their palate. We flip the graft over to the facial, like I've shown you here. Here is just some video from her surgery. I don't normally videotape the surgery, but for whatever reason we did that day. And you're noticing here, as we flip the connective tissue graft over to the recipient site, which is the implant number 9, I've made a slit in the graft, and we're simply going to slide the graft over the tall implant healing abutment, as you can see here. And we're going to utilize that to help support the papilla on the mesial and distal aspects of the implant. And you can see that the graft is plenty long, and now we've actually slid the graft material over the tall healing abutment. Now the next step is to, this is what it looks like. Now the next step is to advance the facial tissue and suture together. Now, in an ideal world, you would refabricate the provisionals to where it looks more ideal. This case is quite a bit older, so we actually did not do that. We just, trimmed out relieved some of the areas in the papilla areas. But we would have gotten a better result if we would have just remade the provisionals. Here's our 5 years post-op. And at this point, Katie is actually pretty happy now that we've gotten her out to 7 years at this point. Her radiograph obviously still looks the same. But for the most part, we were able to even out the gingival margins between the central incisors. She does not have a very big papilla at all, but it's good enough for her satisfaction. So she's very happy at this point. Now, going to our last case, we have a situation where it's truly not management at all. We're definitely on a rescue mission here. We've got a soft tissue correct. We're trying to correct the soft tissue where we have both poor existing gingival levels as well as excessive implant depth. So once again, these are cases that come into our office all the time, and it's very, very difficult because a lot of times, we weren't the ones who placed the implants. We weren't the ones who did the previous surgeries. We didn't take out the teeth. We didn't do any of it, right? The implants are already placed. Now we're tasked with the huge challenge of trying to get the patient to look back to being normal again, okay? So this is the gentleman's smile, very high smile line, very short teeth on top of that. When we look at his case, we don't have any keratinized or attached gingiva, poor biotype, very thin tissue, no vertical tissue height at all. So what do we do? It's very easy to say, let's just take out the implants and start over. But the problem is there's no guarantee that doing that would give this gentleman any better result. So once again, I like to graft early. So even if we do decide to take out the implants later on, I like to graft early just so we have nice soft tissue to deal with. So here we are recommending the VIP graft again. And as we reflect the flap, you'll notice exactly why I did not want to remove the implants, because the bone is not in the best condition to begin with. You can tell quantity and quality wise it doesn't look to be the best. On the other hand, for the most part, the bone levels around the implants, especially around the central incisor, is not terrible. I wish it was better around the lateral incisor, but at this point, we're going to try to do what we can with what we have. So here's the facial flap reflected. With this much soft tissue missing, I chose to do a double VIP CT graft. Now you'll notice here, there's a lingual flap in place where it's all keratinized. So we can't, when we flip the grafts over like this, we can't just flip the grafts over that keratinized epithelium. So we have to take a burr and de-epithelialize the lingual tissue there, so we can flip the grafts over. So this is 2 grafts. That's how it looks secured over the facial, over the entire ridge. There, we're going to coronally advance that tissue and get primary closure. Now healing, of course, this is quite painful, but there's no other way that I could think of at the time to do this. So this is what he looks like sutured. 2 weeks post-operatively, everything's looking actually pretty good considering the size of the graft, but he does have a little bit of soft tissue necrosis on the mesial of number 8. This is what he looks like at 2 weeks and 8 weeks. Now, at the 8-week mark, what was interesting is I brought to his attention that his teeth were very short and square. So I suggested that in addition to restoring these 2 implants, that we also do a crown lengthening to obtain longer, more aesthetically pleasing teeth. By this point, he's once again out of money, tired, doesn't want to do any more surgery. But the problem is he also doesn't like how the soft tissue, when he's in provisionals, he notices that when he smiles, the tissue still looks red and unhealthy. But when the tissue is, when you see the cheeks retracted, the tissue is actually healthy. But what he's noticing is, and patients do notice when they don't have keratinized tissue, what he's noticing is that the tissue is very thin and not keratinized. So it doesn't look healthy to him. So what I decided to do, since eventually I think he's going to do crown lengthening, we can't just crown lengthen the area though, without obtaining more keratinized tissue. And this is just our smile design, just a real quick layout of what I think his smile will eventually look like. But if we lengthen his teeth, we're going to create mucogingival defects. So we have to avoid doing that. This worked out perfect for him because you'll notice on the palatal side of his behind his incisor area, there's a bulge there where this double VIP graft was taken. So what I suggested was a free gingival graft by removing that bulge of tissue that he doesn't like and just flipping it over to the facial aspect. So it gets rid of something that he doesn't like and obtains tissue that he's going to need later. So here we've taken that graft material. I called this the Oklahoma graft because I'm from Oklahoma here in the United States. So we've taken the graft from the lingual and just taken it and just flipped it over. This is what the free gingival graft looks like, fully healed. And now you can see in his provisional restorations, nice, thick, soft tissue. This is his before, and now you can see this is the after. So at this point, he's still waiting to do the the crown lengthening procedure, in which case we'll remake the provisionals. But this is where he's at for now, and this is where we'll stop this case for the sake of time. Here's his before, and there's his after. Much better, much bigger difference now that we have thicker, more keratinized tissue on the facial aspect. That's my presentation for today. Once again, if you have any questions, excuse me, I didn't get to go into a whole lot of detail on some of these cases, but if you have any questions, just hit me up on Instagram. These are my 2 accounts. And Omid, thank you again for having me on your show. It's a fantastic channel that you have on YouTube, and I really appreciate the opportunity, and it's always good to see you, my friend.
Thank you so much, David. Actually, I really want to appreciate you truly from the bottom of my heart. You presented a whole soft tissue course. I think it couldn't be more than that complete, because you covered almost every details in classification, in implants, in teeth, in single parts, in multiple parts, in complicated cases, in simple cases. So I think everything was pretty good covered for the audience and for the dentist interested in soft tissue. So I have a couple of questions that some of them here, so I want to just look at them because the presentation was too long, so I just want to go from the first part to the end part. In the cases that you had envelope flap, especially in the maxillary part, that the patient had lots of recessions and you just reflected the flap, put the derm in both sides, you only kept the papilla between 2 central incisors, and then you closed the flap, and the results was pretty amazing, almost 100% coverage. So my question is that, do you usually completely reflect the flap from the tip of the papilla, or you usually have your flap, I mean, like 1 to 2 millimeters below the tip of the papilla for placing the derm and then close the flap?
Yeah, so that's a great question. That's one of the details I unfortunately didn't get to cover. So I like to use Dr. Zucchelli's principles here, where we actually go, depending on the amount of recession on the adjacent teeth, we do make oblique incisions in the papilla apical to the tip of the papilla. And then what we do later is de-epithelialize the tips of the papilla. So whenever we coronally advance the tissue, the envelope flap, everything matches up to the tips of the papilla perfectly. So to answer your question, it's an oblique incision apical to the tips of the papilla.
So you don't remove the papillas?
No, I don't remove the papilla. So what I do though is, so if you notice this, when we reflect it, when people rewind it, the facial portion of the papilla is de-epithelialized. So it's not totally removed. Like you can't pass a probe or an instrument from facial to the lingual. It's not totally removed.
And when you want to fix your dermal graft or connective tissue graft in such cases, do you grab the flap and the graft at the same time, or you prefer to fix the graft first, like Pat Allen, the way that he do, and flap after that?
So I suture my graft and my flap separately. So I first secure the graft first with sling sutures around the teeth, and then I use a resorbable suture for that. And then I coronally advance the primary flap over the graft and suture it separately, utilizing sling sutures as well. Yeah, so they're separate.
And do you have any? I mean, do you use any sutures at the apical part to make sure that the graft won't move apically? Some clinicians do, like put a mattress in the apical part to make sure that the graft doesn't move to the apical direction. So do you believe in that, or do you do it usually or not?
Yeah, I don't do that. Yeah, I don't place my mattresses in the apical portion. So one way that I do that, because the graft material is already sutured around the necks of the teeth, I don't find that very beneficial for my technique.
Mhm. And one more thing regarding one of the cases that you showed in the lower anterior, that there was a huge deficiency both in hard and soft tissue. So you
Yeah.
did the soft tissue graft first, and then you went for augmentation and implant placement, and because you had a similar case also in the maxilla. So when you do
Right.
that type of grafting first, um, is it going to be difficult in releasing the flap in the GBR stage for you, or there is no problem?
Yeah, so that's a fantastic question. It's a very common question for those people like you who do a lot of this, right? So you know the challenges when you go back in. So the key thing here is when you do your free gingival graft first, the key is to not get such a big piece in the occlusal apical direction. If it goes too deep into the vestibule, then yes, you'll have a very, very tough time releasing your flap at the GBR stage. So the key thing here is to graft it, but don't extend it apically too far beyond the buccogingival junction of the adjacent teeth. And if you do, just go a little bit apical. Don't get too much. If you totally go all the way down to the base of the vestibule with keratinized tissue, you'll then have no mucosa to release the flap for proper closure at the GBR stage. So for me, I try not to go too big in an occlusal apical direction. Yeah.
Yeah, I mean, David, so many great materials for all of those implant cases that you did beautiful soft tissue grafting. I think we can talk a day, but I know the time is limited, and it was pretty comprehensive, and I don't know how to thank you enough. It was a really good time for me. I'm pretty sure it is and will be for all the audience that joined this session and watch your amazing lecture. Want to thank you again for your time, and thank you for accepting my invitation. I'm pretty sure you're very busy with lots of webinars these days. So I just want to say thank you and hope to see you very soon.
No doubt. I miss you, man. Miss us, and we got to get on the tennis court again and get out the selfie stick. I miss all that, man. Miss you a lot.
Thank you so much. Thank you so much.
Take
and
care.
Thanks, my friend. Really, again, thank you for your time, and really looking forward to see you soon.
Thank you. Have a good night. Okay.
You too.
Bye, guys.
My friend. Bye-bye.
Bye-bye.